Hello, thank you, Christian. Thank you for the invitation. It's a great honor to be part of this fantastic meeting and the privilege to talk about an interesting but tricky topic of bleeding in cardiovascular patients. There are a few things why bleeding in cardiovascular patients is a tricky field. First of all, there is no precise data describing the population at risk and suffering from bleeding among cardiovascular patients. Cardiovascular meaning those treated with antithrombic and antiplatelet therapy. So it's very difficult to establish the incidence. It's thought that it's pretty high and higher in clinical practice than in clinical trials, where data are presented regarding very specified and narrow populations, like in those figures here on the right, data coming from a randomized control trial of a very specific vascular scaffold for dual antiplatelet therapy, and on the left, data from a very also specific Asian population of atrial fibrillation treated with oral anticoagulants. The next thing why we consider bleeding in cardiovascular patients a tricky thing is the very, very high clinical impact of the events. It's represented in the population of acute coronary syndromes, where bleeding actually has similar prognosis to that of cases with ischemia. What's more, after 30 days from acute coronary syndrome, the prognosis of bleeding is thought to be even higher than this of recurrent myocardial infarction, what is seen in the figure on the right, where blue stands for MI, red stands for bleeding, and the size stands for magnitude of the events, depending on the type of bleeding. Moreover, bleeding is considered and thought to even increase the risk of ischemic events at follow-up, what was shown in Horizon's AMI trial, again a trial, so a very narrow population specific here with admitted with STEMI, where almost 8% of patients suffered from bleeding after an ischemic event at the follow-up, and almost twice as many, so almost 16% of patients suffered an ischemic event following a bleeding event, all within 30 days from STEMI. The next reason why bleeding is regarded as a tricky field in cardiovascular patients is the very complex step-by-step pathway from the assessment through reduction of the magnitude to treatment. And taking into account the first step, the assessment of the risk of bleeding, we come with several factors, every of them very tricky and very complex. Even at the very beginning of the problem, by defining the bleeding, we encounter problems. We get confused by the variety of scales different between studies, which makes it extremely difficult to compare between trials, between the specific populations. That's why, regarding all the factors, we need to work up some kind of unifying definitions, like, for example, the BARC definition for defining the bleeding. On top, we always have to consider the opposite weighing pen, which is the assessment of the risk of thrombosis in every patient that we consider at risk for bleeding. Going further with the steps, we go to the very interdisciplinary field of the medical branches with the highest burden of bleeding, from 2 to 4% for gastrointestinal bleeds, up to even 50% for intracranial events. Although it's a variety of patients and with many symptoms, many different sites of bleeding, many different symptomatology, they all may have one thing in common, which is they're treating cardiologist or consulting cardiologist who may introduce antiplatelet and antithrombic treatment, which increases the risk of bleeding very much, thus making the symptomatology very difficult, often overlapping the symptomatology of the primary disease itself, which again makes it extremely difficult to identify potential victims of our cardiologic treatment. The final step is the treatment, and It's not as easy as we all think, because we, of course, are equipped with many guideline-recommended strategies for the management of bleeding after antiplatelet and antithrombic treatment. However, as it was said at the first presentation, all the guidelines are implemented in a very low percentage of patients and cases. The ESC guidelines are mostly written, read, approved, and implemented only by cardiologists. So nobody needs to remark us that it's always better to avoid than to treat. And not all of you may be aware of a very fine method, a preventive strategy, which is broadly available, very cheap, even not recommended, but even requested by patients themselves, mostly in Europe, especially in Switzerland, which is a folk method, a medieval prayer called the secret. This is a method. I was also quite surprised while reaching this paper. This is a method aiming at stopping or reducing the bleeding in patients in the perioperative or periprocedural period. So it seems like magic. But Stefan Cook with his team in Fribourg, Switzerland, addressed this in a randomized trial. And randomized patients undergoing or awaiting coronary angiogram to a control group, so with the standard of care, versus patients with the standard of care and the secret. The secret as a prayer was implemented by 14 volunteered secret makers. So these are people who are trained to provide such a method. But the results were not more than expected and showed, of course, completely no impact of this method on the incidence of bleeding. However, patients had a better follow-up in a short term. They reported lower level of stress. So maybe this is kind of biofeedback method, maybe of a possible good future in medicine. Anyway, to address the question if we as the specialists in Western medicine in 21st century, if we are able to influence the incidence of bleeding in a better way than this medieval method, together with my colleagues in Zabrze in Poland, based on the experience from long-lasting cooperation with Christian and his fantastic team in Basel, with the PACE in syncope studies that we are very thankful for, we came up with a registry with the acronym BLEEDACT, standing for Bleeding After Cardiac Treatment, which is a prospective investigator-initiated registry on real-life non-cardiac bleeding among cardiovascular patients, with the main aim to explore the knowledge on the phenomenon of bleeding in non-cardiac departments. With the help of the educational platform of our Polish National Society, we created or proposed a CRF to gather data on the patient-related and bleeding-specific data, and data from the follow-up on the short and mid-term regarding the hard endpoints and the endpoints related to bleeding, all in patients admitted to non-cardiac departments, especially those treated from cardiovascular reasons, with special attention to the type and indication of this treatment, antiplatelet or antithrombic, with the special focus on those patients who experience bleeding either in acute or on periprocedural setting. So unfortunately, I cannot present you any results as we are just about to launch the registry in upcoming months. So my take-home message would be the kind invitation to all of you, the members of the great network, to join this registry to help us solve this tricky issue on the multidisciplinary and multi-center platform. Thank you.
So Beata, thank you for this nice presentation and for highlighting this important problem and for initiating and hopefully leading over the next years important research that will allow us a better understanding this issue. Questions on the topic or possibly for the details of the registry? Yes, please.
Okay, thank you for the opportunity. So my name is Dr. Putri Kamila. I'm cardiologist, so this is a very much a pretty hot debate in cardiology. Most of cardiologists are like, we tend to more cautious or concerned or maybe afraid in ischemic event. We tend to like, we're not really that concerned of bleeding, but we are very afraid that our patient might be getting ischemic events. So what your presentation just now is very interesting in terms of, as a cardiologist, we have to take considerations in prescribing our patients antiplatelet, for example. But my question is, what about maybe giving them a less potent antiplatelet type of medications rather than maybe just shortening it or not giving it at all? What do you think about it? Can we maybe prescribe them with less potent antiplatelet rather than not giving the antiplatelet for the patients? And the second one is, I agree that most of the guidelines is based on Europeans' populations, whereas from Asia, we do have this sense of a higher bleeding risk in Asian patients. And we still use another forms of antithrombotic medications such as like vitamin K antagonists and everything. So we still use that. Do you really think that this can be applied to other population rather than maybe European populations? Thank you.
Thank you for your question. Really, it's a broad topic and hard to close in one question, one answer. However, regarding the first one, I guess that the registry will give us some information about any modification of treatments that would balance the risk of thrombosis and bleeding in the real world. Because all the trials we have, they of course give us some remarks and some indications. However, those patients that bleed, we don't see actually, and we are not completely aware of the problem on the scale in the real life. So that's why we went out of cardiology and asked non-cardiologists of their feeling first, and they feel very happy actually with this topic. Unlike the cardiac surgeons, like we thought, well, it was a talk, I think, first or second, that they are not much happy to join because it was their complication. Actually, bleeding is our complication that makes that is very problematic to treat by other disciplines of medicine. So I hope this would be another side of view and give us some information more. And about the second question, in Europe we also have some recommendations for the high-risk patients of bleeding. And of course, we also implement some preventive strategies, preventive methodology. We reduce the doses, we adjust, we change the agent within the group of drugs. However, again, we don't see what's next actually in the field, out of the hospital. So I hope that our registry will give some answers to this.
Excellent. Thank you, Beata.
Thank you.